all the scientific developments which are happening, particularly for the physicians and postgraduates and everything. Because each and every patient who comes to you is already Googled it up and he thinks he knows everything. If a patient tells you one part about the disease, I always believe that we should tell at least 10 or 20 points which he does not know. So it's up.
And now for the next session, I would like to request Dr. Vijaya Prasanna Babu to please come up on stage and present the presentation for the next session. Now I would like to request MDR Sharma Babu to please.
And I also request our chairperson, our most dynamic leading chairperson of AP chapter of APAPI, probably the best icon for all leading physicians here is Dr. P. Krishna Prasad, who will be delivering the oration today. Now I request the chairperson to present the CV of our speaker, Dr. Krishna Prasad.
Dr. Krishna Prasad, the chairman of the AP chapter API, who is going to deliver today's Dr. oration, is a member of the Association of Physicians of India, and she is the governing council member of the Research Society of the Study of Diabetes in India, and also she is a member of the expert committee group for RSS DL. She is also a recipient of the Sri V. Lakshmi Reddy Memorial Oration in the APAPICon 2022. He is a recipient of the Ramana Bhagavan and Dr. K. Ramachandra Memorial Oration from IMA Vijayawada, and he received an oration from IMA Lord, the Best Project Award and Distinction. She got the Best Project Award and Distinction for the work on diabetic food in fellowship to diabetic from CHC Vellore, and she has conducted more than 3,000 free health programs and awareness camps since 25 years, and she also got the Sri Padma Mehra Award for outstanding services in the field of community outreach by SPM MBB, Best Women Diabetologist Award by RSSDL, IMA President Appreciation Award for Academic Excellence and Community Services, Ugadi Puraskar Award from Delhi Telugu Academy, and innumerable awards for her services. And she was the best outgoing student in MBS from SV Medical College Tirupati, and Dr. among all colleges in the state of Andhra Pradesh. And she has recently been appointed as a non-official independent director of Biotechnology Industry Research Council and Department of Science and Technology by the Government of India in February 2023. Now Krishna Prasad is going to deliver an oration on the past, present and future of diabetes mellitus. As we all know, diabetes is a very common disease, and we see so many cases in our daily practice. And the diabetic, we have the knowledge of diabetes has evolved over a period of time, from the time of glyphosate. Now we have several groups of drugs for the treatment of diabetes,
So I request the chairperson and speaker to garland the photo of Dr. Jogarao. Now I request Dr. P. Krishna Prasad to stay back as musicians and achieve such high goals and attain such high goals. So now I request Dr. Krishna Prasad to deliver the talk.
Good morning, everybody. Respected chairpersons for this oration, Dr. Aguilar sir and Ms. Hassan. Thank you very much for chairing this important oration. And I thank the donor for this oration, the resident physician patron for our APAPA, Dr. Aguilar sir, for honoring me for this prestigious oration. My topic will be the my practice of diabetes past, present and future. When I want to select a topic for the oration, everything is there in the Google. What else I can speak? It's not only the my practice, what exactly was there in the history, it was really interesting. My presentation would be the history of diabetes, changes in pathophysiology, how the treatment plans have been, evolution is there, cardiorenal metabolic continuum, what's new in the treatment, the role of artificial intelligence, what is the future of diabetes management. We know that it's like a ticking bomb of this century. Globally, 537 million adults are living with diabetes. The latest idea Patnas was given. The expected number is 643 million by 2030 and 783 million by 2045. 1 in 10 persons are diabetic. 1 in 3 or 4 live in low middle income countries. Diabetes is responsible for 6.7 million deaths. 1 in every 5 seconds the death is due to diabetes. The latest ICMR in-depth study has given a very important statistics that we are going to see the pandemic and epidemic of diabetes right now globally having 541 with IGT. So rapid increase in percentage of diabetes. This was a lingering question for me for so many years. Is it a new disease? No. When I have gone for the search of the history of the diabetes, it was there from the Vedic period, and I have talked to the Sanskrit Ayurvedic college professors, the principal. I got the literature from them, and what I have seen that even from the days of Charaka and Shushruta, this has been diagnosed as a Madhumeha disease, and it was there from Daksha Prajapati Yajna that has been documented. At the same time, commentators of the Veda has given a Mutradisara name. And very interestingly, main two types of diabetes were described in Charaka period only. The diabetes insipidus was named as Udakameha. That was really interesting. And even in the Egyptian literature, what I have seen is the earliest, in the 3rd dynasty Egyptian papyrus has described the recurrent urination. And in 250 BC, the diabetes, the name has come as like a siphon. Later, a Latin word for honey has been created. And when I have again gone through the history, so many things are there in the literature because to make diabetes today is very easy. But how then to make a diagnosis in those years and how the classification was there, how diabetes was linked to the pancreas, this was really an interesting story. And the reference articles, postgraduates who are interested can go on through it. But one important finding was there in the Paul Lagerhans has noticed in the islets of the pancreas, and what they have seen the two types of cells were described in the islets. Again, what they have seen the secreted chemical insulin has been discovered, and everything was there and documented in the insulin. And for so many 100 years there was a big vacuum is there. Later again in 1908, Juller and interested internist has again gone into the research, and they have found out so many things in the discovery of the pancreas. Then comes the question, what are all the various treatment plans for our diabetic patients? Is it mandatory to use medications for each and every diabetic patient? Does diet plays a major there are unsung heroes in the history of medicine. Thanks for this oration, glad to know about them. There was an important medical journal, Indian Medical Gazette in the pre-independence era, where Dr. Babu Kamashinath Acharjee from Kolkata has reported the first cases in 1867 itself. And in 1872, their thought of skimmed milk has been the treatment for diabetes, and B.D. Basu has given 7 editions of textbook for diabetes. And in 1887, a retired surgeon from Thanjavur, Dr. Muthuswamy, has recorded the medicinal properties, and a lot of research came from Kolkata Presidency and Madras Presidency, and the ophthalmic surgeons at that time, when they were doing the cataract surgeries, they have found changes in the eyes. And in 1907, Chundilar Bose famously wrote that what is the mobility of the implant, diabetes to the aristocracy of India. 1907, British Medical Association Conference dedicated a session on diabetes in tropics at that time only, and a medal has been constituted by Dr. Mitra, and the first recipient of the medal was Dr. Jyoti Prakash Bose. At that time in the Western country, 1921, the insulin discovery has been started, and it's very amazing to know that in 1923 itself, insulin has brought to the India and used by the company Allen and Hadley's at the British Drug House, and they have documented in the children how it has been, the improvement has been the same. It was the first in the literature for India how the insulin usage has been there. He is Dr. Jyoti Prakash Bose, 1894 to 1968, invaluable contribution to the study of diabetes in pre-independence. These are the children, Indian children, what we were seeing all these days, panting and West, they have shown the remarkable improvement after giving the insulin. We know this is traditional in the 100 years of the insulin, how the insulin has been evolved. It is 100 plus years of the insulin. Leonard Thompson was the first patient to receive that with the patent extract was there. And you know the Frederick Banting, West, Petrie, Colin made a lot of contribution. The important log which has given it a very good place in the history, that is a Machori, that is the place 100 years ago has given a vacancy for $1 for insulin, and Banting has given a statement that insulin doesn't belong to me, it belongs to the world. That is the contribution. And those postgraduates, if you are interested, you can search and regarding the history of the insulin, it was a famous story. The most famous patient received insulin, that year was Elizabeth Hughes. So these are children who got improvement after this. 1924, LID was the first company to have the mass production of the insulin and the crystallization of the insulin, how the protein insulin has been dedicated. Now again comes in my practice. If I talk about the initiation of the insulin, immediately patient will go to the another doctor. And patient has a misconception that insulin should be used at the terminal stages of the diabetes management. Particularly the gestational diabetes, if I start insulin, patient may be thinking that we are injecting insulin to the baby alone. There is a lot of physician inertia and poor patient compliance in the day-to-day practice. And if you see how the diabetes definitions have been evolved, in 1955 it was a hyperglycemia due to absolute or relative risk of insulin resistance. In 1968 it was a chronic disorder of carbohydrate metabolism. In 1979 diabetes is a genetically and clinically heterogeneous group. The latest ADA 2023 is type 1 diabetes is an autoimmune beta cell destruction. Type 2 diabetes is the progressive loss of adequate beta cell insulin secretion, frequently on the background of insulin resistance. Gestational diabetes, monogenic diabetes, post-transplantation diabetes, pancreatic diabetes, and secondary diabetes. So, normally we know that we want to diagnose a diabetes by fasting blood glucose, postprandial blood glucose, HbA1c. Everybody knows. I am not going in detail. But what exactly you see on the left side? Now we want to go for the genetic workup because all these genes have been identified and some institutes are practicing the genetic variant identification also. In my practice, in my routine day-to-day practice, for some patients, we do GAN antibodies, we do sequence Later, over a period of time, Professor Nicholson has given 8 pathophysiological mechanisms from the beta cells of the pancreas, alpha cells of the pancreas, the glucagon secretion, the liver, the brain neurotransmitter dysfunction, the muscle, the kidneys, the fat cells, and all these intestines. We want to know this. All our pharmacotherapeutic agents are based on these pathophysiological mechanisms. Now, what again happened? Now, egregious level. Again, few more have been added into the pathophysiology, the immune system, the colon. It has been added. Why? Because microbiota. That microbiota are playing a major role. Brain is also playing a major role. Now again the latest has been added, the paintless protein. So from 3 to 14 in these 25 years, this is a journey where we have to understand. Don't think of only pancreas, don't think of only liver, don't think of only muscle, think beyond that. When patient is not responding to your treatment, think of testosterone deficiency, think of vitamin D deficiency, think of iron overload, think of nerve system. All these play a major role in your diabetes management. Unless you know the history, unless you know the pathophysiology, you cannot understand how to treat some typical diabetic patients. This is the natural history of type 2 diabetes. This is our traditional diagram. Everybody knows that over a period of time, insulin resistance decreases. By the time you are getting diabetes, prior 10 years, the 50% of beta cell apoptosis has been gone. No, now we are not thinking about these things. We want to know about the paradigm shift of the glycemic control to the pathogenesis. Now, the past was there something else. We want to think of preservation of the beta cells, and the future is we want to prevent the complication. I don't want to treat only a diabetic patient the blood sugar report. I want my patient to save his heart, his kidneys, his eyes and everything. So, totally there is a particular the pharmacotherapeutic management, pleiotropic advantages and the protective action. We know that the traditional 2 trials were ACCT trial for type 1, UKPDS for type 2, and the effect was there, the metabolic memory was there, and the intensive glycemic control should be there in the early part of the diagnosis of the diabetes, so that the metabolic memory is very, very important. So we were thinking only about the glucocentric approach. But now what we are thinking, it's beyond the intensive and the conventional control. We have to think of the cardiometabolic arena, which has given me so many trials like advanced trial, abort trial, VADT trial, EDIT trial, and so many drugs like SGLT2 inhibitors like Empalar, Kappa, TB trial, all have proven that there is something else in the diabetes management. It is a metabolic disease where we have to concentrate not only on diabetes, a pre-diabetes, early type 2 diabetes, which we have to concentrate on these metabolic parameters. So, not only your diagnosis, the genes, environment, lifestyle, diet, exercise, insulin resistance plays a major role, and beyond glycemic control, you have to take all these things. I am not going in detailed description of all the drugs. You know the sulfonylureas and the bivalents, all of the inhibitors. These are traditional drugs always used. Later, 10-15 years ago, DPP4 inhibitors were there. Now, for the past 5-6 years, the use of SGLT2 inhibitors were there, and GLP-1 analogs were there. Why I pointed out the rosiglitazone is in 2007-8, that was the molecule which has been taken from the market because of the cardiac case. From that day onwards, any diabetic molecule to come into the market, they should give a cardiovascular safety. That's why the SGLT2 inhibitors have taken a major role, proving that they are having a cardiovascular safety, and all other 2 drugs get there. So when you want to know the treatment part, the drugs which are taking care of all these 8 pathophysiological mechanisms, we are being using now. Then comes the insulin. You know that we have the traditional insulin from porcine insulin, bovine insulin to human insulins, then to analog insulins, then to the analogs like short acting, rapid acting. Now you will be having the future insulins, and all these are Dispro, Aspart, nebulizing, NPH, enlarging, dedimer, degludec, all these are being used in practice now by all these things. But what is the future? The future is the concentrated better rapid insulins, where the drug delivery system will be of different kind. What are all the innovation therapies in the diabetes in the insulin delivery and monitoring? So we know that we have the glucometers, CGMs, now smart diseases are coming, the closed loop systems are there, and insulin biosensors are there, smart patches are there, gluco watches are there. So there is a huge transitional discoveries have been coming into the market, because patients who are using insulin pumps will be coming to you and asking, you should know how to handle that pump abnormalities. What are all the advances in the management of diabetes? We know that the type 1 diabetes is going to change, the total treatment modalities will be changing, and we want to think of the chronic care models, multidisciplinary models. But the major chunk will be on the nutrition, physical activity, stress, screen time, sleep, environmental pollution. What my succeeding speaker will be speaking about that. I want to stress about few important things in the practice. When a patient comes with the retinopathy, we usually see the we go for a city examination and patient goes for the laser therapy, intravitreal injections, all these things the patients are coming. But we want to see that patients should not go for a complication. That is more important. For a retinopathy, we go for a temperature scan, biotissue meter, vascular Doppler, counts and everything. But these days, patients need peripheral vascular angiogram also. Vasculopathy, it is a cardiovascular and a peripheral vascular, ECG, echo, angiogram, CT caption scoring, carotid vascular Doppler, carotid intima media thickness. Nephropathy, albumin, microalbumin, protein creatinine ratio, albumin creatinine ratio are the biomarkers. Diabetic food, don't stop with X-ray food. You need MRI and CT in some patients. The gut microbiota, the sexual dysfunction, female sexual dysfunction will be taking the major part in the future. The cognitive dysfunction, dementia and diabetes is again a very big thing which we have to take care. This is my laboratory where all these instruments are useful in my practice for different patients, and unless we improve and update our practice and gadgets, we cannot do justice to all patients. Then comes what are all the patients' expectations in our practice. Patient first question is, I don't want to have lifelong medications. He wants complete cure of diabetes. He wants reversal of diabetes. Type 1 children doesn't want to have the insulin injection. Patient doesn't want to have the glucometer drip. And patient, a diabetic mother, a gestational diabetic mother comes and says, my child should not get diabetes. And patient wants to eat everything on the earth, and how he can give that answer to them. Patient gets that, is it because of my diet or stress or sedentary life? Why people are having so many complications these days? What are all the drug interactions given by a cardiologist, nephrologist, urologist, and a dump of bags of medicines are there? What to be done for the future generations? What are the answers for this? Answers for this? Every time I think we had extensive discussion on the diet in diabetes. These days, Veeramachanari diet, keto diet, paleo diet, vegetarian diet, the Dikshin diet, so many diets are there. How many medical postgraduates are having full knowledge about diabetes? You should not think only the glycemic index, you should think of a glycemic load. Dietetics is again a big chapter, a book has given by Dr. Meenakshi Bajaj from Madras Medical College. App-based calibrations are there. Can you recognize that figure with the audience? I thought what is there in one of the 5-star hotel, a fermented gut probiotic diet was kept as an English name. And I came to know it is our Satyanam which was eaten by our Dadis 50 years ago. That is the diet to be advised for a diabetic patient. Now some people are promoting it also. But Hippocrates told few centuries ago that food is the medicine and cooking is the medicine. So what do you want to do in future? Again you have to go back to your history. So the traditional diet, that is the junk diet, where we stand up, what to be done for our future generations is stand up to the diet alone. This diabetes revision is a myth or reality. This is very important. American Diabetic Association has given a clear statement that revision should be defined to there. Then what's new is there? You know SGLT2 inhibitors. These days you know empagliflozin, canagliflozin, dapagliflozin, everything is there. But the new thing is dual SGLT2 inhibitors. Imeglimin is again a new compound everybody wants to use it because the mechanism is action is at the mitochondria. Oral semaglutide very interesting because it is a oral GLP-1 analog. The cost is there. Patients are using for the obesity and everything. And type 1 diabetic patients always ask, what is the oral therapy for us? Is there any new drug is there for us? So this is a teplizumab injection to delay the onset of stage 3 type 1 diabetes. It deactivates the immune cells, then it can be administered by IV infusion once daily for 14 consecutive days. Then comes the question, what is the stage 3, what is the stage 2 of type 1 diabetes? You can read the ADA 2023 classification. Unless you know it, you cannot understand it. Then comes the insulin. I don't want to take daily insulin. I want to have a weekly insulin. I want to have a yearly insulin. These are the once weekly icodic insulin is there. The depot releases are there. Once weekly basal insulin is there. And it has been in the process and definitely the phase 2 trials are going on. Then comes, can we take insulin other than the injection forms? Is it really there in the market? Inhaled is there. Exubra, Capriza, they have got. Oral insulin is there. The memory technology has been tried. Nasal buccal transdermal insulin has not been in a very success. Intraperitoneal insulin is there. Colonic insulin delivery is there. And artificial pancreas is there now. This is a very new innovative thing. The smart insulin, the glucose insulin, responsive insulin, the next generation insulin, a designer insulin. It can be injected once daily. It can itself make out the glucose history, and it is in the pH sensitive polymers for the smart insulin delivery. Then what is the other new insulin? That is the insulin F. It is developed by Wagner et al. Modifying insulin with the phosphorin and glucose transporter inhibitor. It is capable of binding to blood on erythrocyte host, which can be inhibited by glucose and cytochalasin B. Then comes the insulin patches. Recently, one of the type 1 girl is coming and asking me, Madam, when will you start using the insulin patches for me? So patients are updated with the knowledge. You should understand how these painless smart patches are useful for the insulin delivery system. It is still not there in our country, but is still in the process of the trials, which is very interesting, and it is proactive use is there. And what is the new technology in the future diabetes care? What is there? It is a Google Smart Lens is there, needle-free revolution, smart penicillins and artificial pancreas. The smartphones usage has been there enormously increased used by software professionals because of fast internet, email communication and larger food and carbohydrate database is there. The pen itself, all the checks, the card count and everything. Bluetooth data transfer is there, and this has been extensively tried in the COVID period also. The Google Lens, it has been developed. It will sense the blood sugars in your tears. So that is a very interesting thing. The chips and sensors have been tried. The prototype has been generated for reading 1 per second. This is again a smart insulin pen. It is a reusable injector pen with a smartphone app, and the calculates and tracks the doses. This is very important. Many of the type 1 children, those who are interested, they want to have all these kind of the latest gadgets. Then comes the question. For the past 2 months, everybody is asking, what is the role of the artificial intelligence? How ChatGPT is going to take care of you? 1 week ago, we have seen that all the doctors missing on diagnosis of a child in the Western country. With the artificial intelligence, the answer has came. So how it is going to change the life of a diabetic patient? Diagnosis, treatment, lifestyle, diet, carb count, calorie count, exercise, number of steps and sleep. So the future postgraduates of general medicine can take up this, and you can have a very bright future because artificial intelligence is the next frontier in the diabetes management. Already in 2018 itself, the artificial intelligence approved devices have been used in the batteries, the Guardian Connect system by Medtronic. I have gone to the Delhi, one of the digital technology conferences, where we have a demo of all these devices, and many of any doctor can, with your smartphone or iPhone, you can say, take the photos, it will give the picture, on the picture, and the appropriate cases will be sending for the management for your diabetic retinopathy. The closing loop systems, all this there in the artificial pancreas. So this is the future of the diabetes, where we started from the Vedic period of Charaka Shishra, how the 100 years back insulin discovery was there, how your sulfonylurea metformin was there in the practice, your traditional insulins were there. Now comes the role of all the latest standards. The future is for the artificial pancreas, and you should know our diabetes management is not going to be stopped here. The future is very bright. So these are the closed loop systems are there. Those postgraduate students are really interested to know about systems and everything. Workshops can be planned at respective medical colleges. Some training can be given so that you can understand. We can really give to the affordable patients written diabetes, glycemic variability, type 1 diabetes, gestational diabetes. All these insulin pumps are very much useful to the patient. How does artificial intelligence in insulin therapy is going to be useful? The real-time artificial intelligence assisted insulin dosage titration system is very important. Recently, Dr. G.R. Sridhar sir, Professor of Endocrinology from Visakhapatnam, has given an excellent article on the artificial intelligence and ethical issues, and the privacy, the data availability, and the legal issues. Anybody interested can search that article. A wonderful article on the artificial intelligence. And what are all the new therapies in the future? Now any advertisement is there in a corporate hospital, patient comes and asks, I want to go for a surgery for diabetes. If I go for bariatric surgery, my diabetes is removed. If I go for a pancreas transplantation, my diabetes is removed. If my islet cells are removed, my pancreas is removed. Patients are asking all these questions. The stem cell therapy, patients are asking. Now the umbilical cord is being donated and being preserved in all the stem cell banks, and the future is for the stem cell therapy. And future is all the gene therapy for the diabetes, because already 30 genes have been identified. And I take one simple example, sorry. In neonatal diabetes, if one gene is identified like TCH7, if the gene has been identified, you need not give insulin. You can give only glycosamine off tablet for the patient. So this neonatal diabetes, diabetes in all these childhood diabetes, the gene therapy is going to matter a lot for you. Then what is the future scope? Personalized medicine and the precision therapeutics is the day of the diabetes management. In RSSDA 2022 expert guidelines, my chapter, my topic is on the precision medicine, where we had an extensive literature that you can't write a sulfonylurea metformin like in your 104 vehicle or government supply. Each and every patient cannot be given all these drugs. You have to identify which patient is going to respond to which oral anti-diabetic drug, and your treatment depends on that. So the advancements in the genomics, the molecular profiling techniques can contribute to personalized medicine approaches in diabetes management. So this is very important. Checking a blood glucose with a glucometer is not the management for the diabetes. What are the emerging targets in the treatment of diabetes? Extensive molecules are there. I am not going in detail, but just to point out to that, these are all the enzymes where they have been targeted for the treatment for diabetes. Not only the PPR hormone, nuclear factor, piprilicin, AGBT, these are all targeted for management of diabetes. All the new molecules have been tried, all these receptor molecules for the benefit of the diabetes management. So then the concluding is monoclonal antibody therapies have been applied in the diabetes management to alter the diabetes progression by deleting the immune effector cells, particularly in the type 1 diabetes. This has been in the trial little bit impressive, because a type 1 diabetic child doesn't want to take insulin. He wants to alter the immune system by all these new therapies. So what are all the take-home messages? Diabetes management is an art of practicing evidence-based medicine. This is very, very important. You need to follow the guidelines. Never treat the numbers. Always treat the diabetic patient's symptoms. Diabetic patients need empathy and sympathy in the management of your all pathies, neuropathy, vasculopathy, nephropathy and retinopathy. Don't threaten the patient with future complications, but caution the patient on the risk of poor compliance and its complications in diabetes. Good communication skills with diabetic patient will increase your practice for generations to come. Never underestimate the knowledge of diabetic patient irrespective of educational and financial status. Every diabetic patient is empowered with knowledge through social media in present era. Build trust in the patient with your practice of guidelines in treatment plans and patient trust you forever. Patient has liberty to choose any system of medicine and he will use all systems of medicine simultaneously. He takes for you homeopathy for his allergy, Ayurveda for his joint pains and naturopathy, but your prescription will be there, you will be breaking your head. So don't differ with opinions of doctors of other systems of medicine. We need to accept the reality that Ayurveda, homeopathy, naturopathy, Siddha, yoga are recognized specialties by government. Document all your clinical findings, biochemical parameters, suggestions for future investigations to save yourself medico-legally. Never criticize your doctor or their prescriptions in front of the patients. Every patient is a teacher for you and accept this truth in your life. Because they are subspecialist, super specialist knows everything about something only. A specialist knows something about something, but physician knows something about everything. So the lessons learned in my practice are: diabetes is a sweet disease with bitter complications. Give good food to the birth to give birth to the normal child. Give good eyesight and vision to see the colorful world. Give good senses to walk on the barefoot on the earth. Give pleasure of eating food to enjoy the healthy life. Give both feet on every diabetic patient to enter their own grave. Save your organs. Eat less and work more. Less digital time, more sleep time. Eat more raw food and eat less processed food. The diet is very simple. Healthy lifestyle modification, work balance with professional life and stress management. We need a good metabolic control. Not only the blood sugars, blood pressure, lipids, everything, a holistic care approach. Physician is the supreme commander and the diabetes management. A very long journey. The Chandamama Rave is the whole story by the mother. Now we can land on that is a very long journey. The first insulin pump few years ago is on this side. The smallest insulin pump you are seeing on this side. A single chapter in the medicine textbook of diabetes has turned into the international editions of textbooks of diabetes. So the journey is very, very long and a very good foundation has been led by our Indian physicians. A wonderful discoveries are there. If you have seen the history of medicines and all these legendary physicians made our life a better, easy way of treating all the patients. I thank Almighty for making me doctor to do service to the society, and I thank all the persons who have led a very good pathway for my life, and I thank all the legendary physicians of APA and APAPA for making us to travel a very smooth life in our country. This is my final destination. Thank you very much, and I thank